Good day, gentlemen. Good day, ancient lady. Good day, colleagues and students, and fellows and residents, and everybody listening to us. I am delighted to talk to you today, together with esteemed colleague, about a very interesting study that we had the opportunity to review and to read in the recent past. My name is Dr. Rodolfo Savica. I'm a professor of neurology at the Mayo Clinic, Rochester, with a particular interest in neurodegeneration, neuroepidemiology, and biomarkers. Today, we're going to discuss a study entitled Association of Neurofilament Light with the Development of the Severity of Parkinson Disease. And I would like to now pass the word to Dr. Choudhury.
Hello, everyone. Welcome to the NVIDIA Journal Club. I'm joining Dr. Savica today to discuss a study by Holloway and colleagues. I'm a cognitive neurologist at Bannerson Health Research Institute, and I also have an interest in Lewy body disorders and overlap and biomarkers. So this is a very interesting study for us to discuss. So without further ado, we'll get started. So this is the paper, so that the reference is available for folks to go back to. And I wanted to start off by framing the study in terms of the need for biomarkers in Parkinson's disease, but also neurodegenerative diseases in general. So diagnosis of Parkinson's disease is still clinical and can only occur once symptoms are present or patients present to us with symptoms. And diagnosis is still fairly time-consuming in a clinical evaluation, but requires understanding and figuring out of nuances, and having diagnostic biomarkers would really move the field forward. We do have some DAT scan being available in the United States, and we do understand that there are some prodromal states, such as REM sleep behavior disorder, but there are many others that we understand very little about. So the need for blood biomarkers in neurodegeneration in general, but Parkinson's disease is great. And I particularly like this figure that was in the accompanying editorial by Dr. Parnetti, where the use of biomarkers in the field was pretty well illustrated. In terms of using it for at-risk individuals and perhaps even in differential diagnosis and disease monitoring. And I want to stop here and ask Dr. Savica if you have any thoughts about where we are in terms of the field in using biomarkers.
Oh, thanks, Dr. Choudhury. That is actually, I agree with you. This figure is very well able to depict where we are at, and showing the way biomarkers in general, not just in degeneration, are working. Clearly, especially in Parkinson's disease, we are in desperate need of having ability to not only have early detection, but also have a clinical confirmation while people are alive of what's going on. Because unfortunately, as you know, and as everybody knows, the final diagnosis is still belonging to the pathological findings in autopsy. And the final diagnosis is still characterized by the presence of accumulation of Lewy bodies in the pathological report. However, we know now, and this is relevant for the biomarkers, that within Parkinson's disease, but let me stretch it forward, between degeneration, there's an enormity of different types, subtypes, and different mechanisms that are leading to a potential common outcome, which in this case of Parkinson can be alpha-synuclein deposit. But sometimes we do not see even alpha-synuclein deposit when we do the pathological results, and patients have a good response to the medication. The case of Parkinson, to me, is very interesting, and I would like to see what you think about it when we have a group of clinical criteria. So we have clinical diagnostic markers for the diagnosis, but also we have an important aspect, which is response to treatment, which is a therapeutic marker, basically telling not only therapeutically what could happen to the patient, but also can tell us, can confirm the diagnosis. And it's one of the few times in neurology where you have that, because in Alzheimer's disease, it doesn't really happen. Even in dementia Lewy bodies, it's not really happen. However, people can say that the dementia Lewy bodies and Parkinson are very much similar sometimes. So in a situation like that, having the opportunity to confirm that we are dealing with a condition that may respond to treatment and potentially also giving us the opportunity to identify earlier condition, to do trials of potential neuroprotective intervention, it's phenomenal. Unfortunately, what we know now is that everything is quite specific. Means that, okay, we know that over 90% of patients that have dream and active behavior disorder will develop some sort of synucleinopathy, but we don't know when. We don't know if they will develop in their lifetime. That's a big problem, and that we need to be thinking, as well as we have very little knowledge about combination, and we will discuss further about it, combination of multi-layer aspects of diagnostic biomarker, molecular biomarker, predictive, prognostic, monitoring biomarkers, severity and progression biomarkers that can change the framework of a disease at the individual level. So in a situation like that, this cartoon that was made by our colleague Gaetano Parnetti in the editorial accompanying this particular paper is quite important, because it's telling on how we are seeing different level, different kind of potential biomarker in the CSF, for example, in the blood, or who knows where else, in the saliva, who knows where else, that can have a role. And Dr. Choudhury, I want to ask you, what is your take when you see this particular graph? To me, reminds me a lot of what we see in Alzheimer's disease.
I was just going to say, I like this graph because it follows sort of Dr. Clifford Jack's graphs in Alzheimer's disease. And I guess we will talk about this perhaps even at the end of this, but sort of moving towards a biological definition of Parkinson's disease, or you know, and perhaps moving towards a biological definition of all neurodegenerative diseases in the future, particularly when co-pathologies are common, and having clinical symptoms of Parkinson's disease doesn't necessarily mean that other pathologies are not present. And once we start to determine the different types of biomarkers that either give us pathological certainty, or just more general neurodegenerative disease certainty, and at various different stages of the disease progression, I think that will become really important in not only clinical aspects, but also designing clinical trials for disease-modifying therapy. The more diagnostic certainty we have, and the more understanding we have of pathology ante-mortem, helps us really target symptoms and know what medications and what disease-modifying therapy is working for what.
Absolutely, I entirely agree. Also, not only pathology, but also the biochemical mechanism, because we are talking about biochemistry, the biochemical cascade that is leading there. That is leading to whatever pathological activity, whatever disease is coming. If you're able to find ways to reduce, delay, modify these cascades of events leading to a potential common outcome, not necessarily, we may have identify a potential target for treatment. And that's, to me, is what our the future studies and the current studies needs to be focusing on, and the current generation of colleagues, students, researcher would be nice to be focusing on, because clearly, and we will see that, not necessarily some biomarkers, everybody will have to do a diagnostic biomarker, but it's not what sometimes can be done, and it's not what sometimes the data are leading to.
Yeah, so this is sort of great framework for this particular study. And I sort of want to talk about why neurofilament light chain was chosen, and how this is a neurofilament light chain is sort of becoming a very important marker in all of neurology for that purpose. So quickly, for listeners who are not familiar with this protein, it works for maintenance and assembly of axonal cytoskeleton at the very basic level. And really, any sort of large myelinated axonal injury will release this protein into the CSF, and then eventually we will be able to detect it even in the serum and blood. So this can be seen in a large number of neurodegenerative diseases and neurological diseases, ranging from multiple sclerosis, Parkinson's disease, Alzheimer's disease, as well as traumatic brain injuries, and even in some recent studies in NPH. So it is a very non-specific but attractive biomarker for degeneration in general. And so far, we have looked at several studies in many of these different diseases, but in Parkinson's disease specifically, the results have been a little inconsistent. So initially, we thought that Parkinson's disease itself perhaps doesn't have an increase in NFL levels compared to atypical Parkinsonism. So it was thought to be perhaps more diagnostic in differentiating the Parkinsonism versus atypical Parkinsonism diagnostic criteria. But in more recent times, in studies in PPMI, so the Parkinson's Progression Markers Initiative study, there has been correlations between increased NFL levels and motor severity, cognitive function, and perhaps even an early prognostic marker in these patients. Dr. Savica, this is a different type of study, but in part, the PPMI has been aggressively looking for markers for a while, and NFL has now started to emerge even in Parkinson's disease. Do you want to clarify any other thoughts you have about looking at PPMI versus a study like this, where it's just looking at a community population?
Well, the relevant part, this is a very good point. So there has been a number of initiatives through the years, try to collect blood for many different reasons in Parkinson. At the beginning of the late 90s, early 2000s, there was this genetic revolution. We were thinking, oh, we're going to solve the problem of Parkinson's disease using genes, and it didn't work. And for a while, there was these other initiatives, including this initiative that is sponsored now, that is supported by the Michael J. Fox Foundation, that is being indeed now over 10 years of study, with the idea of trying to identify all sorts of potential biomarkers, not necessarily one, but a lot of them, not necessarily NFL, but a lot of others, with the opportunity to collect blood, urine, CSF. Lately, I think they're going to do also skin, and some cases are having that imaging and MRI. So clearly, a study like PPMI has the opportunity to explore multidimensionally many other aspects. The downside of the PPMI is that it is not homogeneous, in the sense that it's coming from many different centers around North America and sometimes the rest of the world, which is good and bad, because allows to have an increased potential generalizability when you have the results. But on the other hand, in a situation like Parkinson's disease that we talked before, where you need to have a very set and clear clinical criteria that are dependent many times by the expertise of the neurologist or whoever sees them, you may have some issues. Overall, there's not a perfect study. PPMI is a great study. This one also, the one we talked today, is also a very good study. We're going to tease it out, but I think it's an excellent study, the one that we're about to be talking by our colleagues in Rush in Chicago. So it's an excellent study. Those are excellent studies, but they have different abilities, different opportunities, different way to explore the same face of the problem. Also, one of the things that is really important is that we need to have the opportunity to understand the progression. And to see the progression, we need to have ability to collect people through time and have homogeneous data through times. A study like the one we're going to talk about today, the RUSH, is really good because the same people are doing the same thing. Then we can argue how could it be done better or not, but that is a very important point to make. Also, let me say something that you said is very well. This NFL, should we use the NFL, is something that is very important. The editorial that is accompanying this manuscript to me is also very interesting. Is reusing a concept that was used some time ago when they were calling NFL the C-reactive protein of the brain, which is true. C-reactive protein, as you know, is increased in anything, anything that we may have. I don't know that NFL is increasing on everything you might have, but every time there's an axonal damage of any sort, NFL can increase. Now, is our role, is the study's goal to try to correlate correctly with what's going on? Because clearly, I see NFL much more useful already useful in some condition, in some diseases, for example, ALS, more than in others in this moment, just because it's a little too specific as a concept. And either the PPMI or a study like the one we're going to talk today, here done in the Chicago Health and Aging Project, have to face the challenge that they can be elevated for many other reasons.
And so that brings up an important point, which I was going to bring up later, but we might as well talk about now, is the understanding of elevated NFL levels in blood and CSF in the context of other medical conditions is not very well understood. Does it change by renal disease? Does it change if we have heart disease and, vascular disease, all of which is very common in our population?
Absolutely.
Does
it changes with age? Age, right? Plaques and tangles and neurofibrillary tangles can be present as we get older without Parkinson or dementia. And we know also, and we need to tell you, but for our listeners, 20% of patients have going out to autopsy are having synuclein deposits, Lewy bodies, and it's called incidental Lewy body disease, and it can be elevated there. There's something about this study done at Rush that is interesting about we will see the gradient, the gradient of severity that can be interesting, finding a threshold that can potentially lead somewhere else. But obviously, and this is an important point I want to make later, but we'll start to introduce the concept now. We cannot use, in this moment, there's no such thing as a single individual biomarker that is telling you whether you have a disease or not. Neither in the skin, neither in the saliva, neither in nothing. I'm going to push the concept. Even a positive DAT scan without symptoms doesn't give me the idea that this person has currently Parkinson's disease. They may, but so far, symptoms are the ones that are leading the diagnostic journey of our patient, the prognostic journey of our patients.
Yeah, so moving on to the objective of this study then, what they really wanted to look at was 3 different things. One is whether an elevated serum NFL is associated with a clinical diagnosis of Parkinson's disease in their follow-up. Parkinsonian signs that we associate with Parkinson's disease, so they used a modified UPDRS for this, and particularly they focused on bradykinesia, rigidity, tremor, and gait. And then finally, changes in overall physical functioning. So they used different types of timed testing, standardized manner to get to this, and we'll talk about it in our next slide. So first I want to talk about the design of the study population, because for folks that are not familiar with the Chicago Health and Aging Project, This study has been started since 1993 to 2012, and it is a community population. So essentially, these folks went to the community of 3 different neighborhoods and did a census and said, would you want to be participatory in our study? Then they did a baseline evaluation to identify disease-free versus folks who have some sort of neurodegenerative disease. And once they identified the disease-free states or population, they then randomly sampled them every 3 years to do a full clinical evaluation that included somebody going to their house and actually going through all of their medication lists, their full medical history, etc. A clinical nurse who was well trained to examine these folks and bring back all the evaluations. And then also they did random blood sampling. And a neurologist then reviewed all of this findings to then determine whether they had Parkinson's disease or not. And they also had some cognitive testing that determined whether they had cognitive impairment or not. As you can imagine, every 3 years or so, there may be some attrition in the population. So the way they dealt with that is that they introduced a new disease-free state every 3 years, who then had a baseline when they got introduced and then in follow-up evaluations overall. So this is the overall study. Dr. Savica, does that sound correct? A stratified sampling?
Yeah, absolutely. And it's very nice because clearly it's a good way to keep, we try to keep a good sample size, because our listener can think, right? If somebody is being certified disease-free and let's say he or she is 75, it's possible that when they are 78 or 82, they're going to pass and they're going to leave a blank spot. So the possibility of adding more patients in the same way and having the opportunity, and that's what I love about the Chicago Health Study project, is that opportunity to look them 2 times with 3 years interval allows them to see how things have changed. If you and I are thinking about 3 years ago, our life has changed markedly, and not because we were under the pandemic, but because it's normal. That is changing. You have diseases, you have situation, you have whatever. So it's very nice. This is a very nice experimental study. Actually, to me, is a very good example on a community-based approach with a very strong scientific ideas behind. Something that you will do with mice, basically. But rather with mice, you do in the real world, in a real scientific approach. So I invite all our listeners to read in detail the methodology of the study. That is not the purpose of this conversation, because it's very well done.
And I'll just point out 2 other important aspects of doing such a random sampling is that it gets rid of some of the biases we have in terms of randomly sampling them every 3 years or so. So we're not just doing the same cohort, but also it reduces cost, which is one of the major issues in doing community studies as well. So I like that about this study quite a bit. So this was a great study to do this on. So like we said, the diagnosis of Parkinson's disease was made by a neurologist, and then the Parkinsonian signs were used with the modified UPDRS scores, and they gave them a global Parkinsonian score. So 0 being 0 and then 100 being the most. And then physical functioning, they used standing from a chair, tandem standing, tandem walk, timed walk. And for each of these components, they gave a score from 0 to 15, where lower scores indicate more impairment. And then they kind of also did a composite score of it, where again, lower scores indicate more impairment. So ultimately, they found that they had about 454 participants who had more than 4 blood samples in their entire cohort. And so they included all of them because they would have the largest amount of NFL levels. And then they did a random sampling for the rest of it, for the total of 1327 participants. Again, I think that reduces the bias. And overall, in their 1327 participants, they had 77 with incidental PD diagnosis. Does that appear in normal with terms of epidemiology of PD?
Yes, it appear normal in an age population. I would say in the population below the about the age of 72%. So clearly, as we get older, people we were saying, and our teachers are saying that if everybody is 150 years old, everybody will have Parkinson's disease because the depigmentation, the basal ganglia, would be occurring as we get older. It seems to be quite right. Actually, it's a very I know the numbers may seem small, 77, and this is one of the limitations of the study. 77 is not a huge number, but on the other hand, I wasn't expecting more. If in a sample like that, I'm having out of 1,000 participants, we're having 500 Parkinson patients, we have a problem. We have a huge selection bias, means that, as you say before, we were including patients that were somehow prone to the disease and is not looking good. It means that, yeah, it can happen in some pockets of population where Parkinson maybe is more frequent. But if you're talking in a general population, it should not happen. So it sounds to be about right.
And one of the important aspects of this study is that because of the neighborhood that they sample, there's a significant Black population in this neighborhood. So, I think given that the epidemiology fits in with what we know in other studies where there is not a lot of African-American population is also helpful for us in this study.
Well, see, as far as we know, is that almost we will see that 61%, I was looking at that to make sure 61% of the participants are Black, which is great. It means that why it's great, because the epidemiological studies are all limited in this moment with all the different, we mostly have some problems with race, in other words, so we are not having some race and ethnicities are not necessarily well represented. And there's a huge effort to the epidemiology community to try to involve and make sure that everybody is represented, because otherwise we will not be able to get fair and stable numbers, stable figures that can lead policies, legislation. I know I'm drifting a little bit, but if we don't have stable rate of a disease and we don't know the rate is right, nothing will change for a disease, because if the disease is more common than what we think, governments will allocate more funds for research, and advancement of that depends on the epidemiological findings on that. So the fact that we had data about Black population in Chicago is very important.
Yeah, couldn't agree more. So I want to start with the results. So this is a unusual looking table 1, but I wanted to orient our viewers to what's going on here. So what we're seeing here are odds ratios of folks having neurofilament light chain levels in their serum and divided into 4 quartiles. So if they were below 18.5 picograms per mil, they were used as the reference quartile. And then this is the second, the third, and the fourth quartile. And whether the odds ratio was higher for clinical Parkinson's disease, the global score of Parkinsonism, and the different subset scores overall, and then for each quartile, and how there is firstly, overall, there is a higher odds ratio of being diagnosed with PD if you have a higher blood concentration of NFL. But the odds ratio is graded, meaning that the fourth quartile seems to have the highest odds ratio, and then the third, and then the second, and so forth. So when looking at this, both for clinical PD and global score, there is a significant odds ratio in the fourth quartile, but I would say in the second quartile, things are not as high. I think it's a little more iffy. But if you look at particularly the gait score, even in the third quartile and the fourth quartile, things are looking to be predictive of Parkinson's disease, or at least gait as assessed in Parkinson's disease. And so rigidity and tremor was more absence versus presence. And you can see how the scores there are less kind of lukewarm compared to a clear scoring pattern. Dr. Savica, any things you would like to add?
Oh, absolutely. That is very important because despite clearly the identification of quartiles is an artifactual classification. So it's been done by our colleagues to try to identify different potential ranges that can identify a condition based upon the distribution of the results. So can be viewed as artifactual, but to me is not in this case, because clearly shows a little trend, show a trend that is not necessarily being, and that's something that to say, is not necessarily being analyzed, the trend per se in this study. So there would be one of the limitations that is not being totally analyzed, but is a trend. And I don't see, by the way, talk about this right away, because it's irrelevant to this. I don't see our ROC curve, rock curves. I don't see that. And that can be problematic for specificity. But anyway, it's not a matter of that. But the trend is telling that the more the highest is your level of NFL in some aspects, and that's very important. In some aspects of the symptoms that have been noted, the highest it is, the more likely that the symptoms are there. And that's a big deal because it's telling already, and that's an important behind the line message, that NFL or any biomarkers may be good for a condition, may be good to tell you something about a condition, may be good to identifying a subtype of a condition, something that is pointing toward a specific manifestation of a disease in a specific way. And this is an example, because clearly we can say, if me and you review that and read that, we can say clearly gait and bradykinesia. So people that are maybe more in the akinetic, slow, Parkinsonian aspect may have positive NFL. Whereas people that are tremor predominant, that by the way, is considered more benign to start with for many different reasons that we are not going to go into detail there. And we know they have a better survival already. People that have tremor predominant Parkinson's disease, they don't seem to have this massive axonal injury. The thing that I am a little not confused, I wish we had a little bit more understanding of the subtypes there, is the rigidity. Because in rigidity, you still see in the last quartile, in the highest quartile, an elevation compared to the 25.4 and the 18.5 quartile, but still is not as marked as you see in bradykinesia or gait score. So we need to be understanding what was there. Maybe it's to do with the scoring, or has to do with the way the symptoms are being collected, rather than an actual effect right there.
And this is sort of in keeping with the studies so far, looking at motor progression of Parkinson's disease populations. And additionally, bradykinesia and gait are not independent of each other. They can affect each other, which also sort of says why they are so perhaps interrelated and higher in terms of their odds ratio in this NFL.
Let me say also that all the scores here, or the global score, the only score that doesn't seem to be having significant effect is tremor to me. Tremor clearly doesn't seem to be involved in this axonal damage. Almost, I'm exaggerating here, but doesn't seem to be, NFL don't seem to be necessarily, doesn't seem to be increasing people that have more tremor than not, which is again a very important information that we can get in between the lines, in between the message of this manuscript.
And so following up on that, when we look at the baseline functioning scores that they have done, and they've done a similar analysis again with quartiles, and here negative means worse, hazard ratio because the inverse relationship of lower scores being worse in this case. And these kind of go together. The composite score is obviously showing up as worse, whereas if you look at tandem stand and chair stand, they're not significantly worse in the second and the third quartile, but clearly all taken together, the composite score shows some level of worsening at baseline, but also there is an annual rate of change. And I think the annual rate of change, honestly, is better depicted in the figure here, because the numbers don't always make sense to me, but figures look nice. So here you can look at physical functioning, overall physical functioning, and the top quartile, you can see that the slope is going down, and obviously similar for every single quartile. And if you just look at the slopes over here, you can just see that the chair stand and the timed walk have better or more negative slopes than the tandem stand does, and therefore it's not as easy to detect, I should say, the tandem stand difference than it is for the chair stand and timed walk. Again, maybe correlated with bradykinesia and gait scores that we are seeing. The one thing that they did covary for here was cognitive impairment or some level of cognitive functioning status, but obviously it's very difficult to covary for things like MSK problems, back problems, hip changes, all kinds of things that affect our global functioning. So those are things that may also be affecting this overall score.
Well, those are conditions that seem to be present as we get older. That's the point. So it's very difficult to test in this way. Sometimes I would say some more advanced, but rather impractical for this kind of study technique that can identify gait in a specific way can differentiate musculoskeletal diseases with neurological diseases, and with neurological diseases, stroke versus Parkinson versus whatever. But clearly, it is impractical. It's not something that can be done with an in-person visit in the house of the patient. It has to be the opposite. The patient should come to the center, and sometimes it's good and bad. So clearly, we have to find always the balance in what can be done, what would be done, and what would be improved. And sometimes it's not possible.
But in the future, we could foresee some sort of monitoring device that monitors gait, and perhaps in the future that can be complemented.
But we already have that, so it's not yet used. I mean, clearly, the vast majority, the wearable devices is something that people are using, or even again some of the gait maps, the gait tabs, and so forth. But overall, what we can do it is used in computer graphic for cinema and for video games. The tracking of the movement can be done just with a camera. You need some very little references nowadays. In the past, you need to have a lot of reference. Nowadays, you don't need very many reference points to understand the movement. So I think in the future, this study will benefit for sure. Similar studies will benefit for sure of some sort of device that with minimal effort can, in real time, provide information on how the movements are occurring.
Absolutely. This, to me, was the most interesting result of the study. One of the things they did here was stratify the collection time of the NFL with relationship to diagnosis. So at diagnosis of Parkinson's disease, between 0 and 5 years prior to diagnosis, and then greater than 5 years before diagnosis. And I thought this was very interesting at that is that in the highest quartiles, even greater than 5 years prior to diagnosis, we are seeing increased hazards ratios or increased serum levels. And this kind of carries out, but again, very obvious in the gait scores and the bradykinesia scores. And I think this is interesting, getting to your point about some prodromal states might actually be more amenable to the use of this biomarker than others.
And you can see also the tremor, that basically, if, let's say, our colleagues would have published this data just with tremor, the study would be a negative study, basically. Okay, so because it's clearly not something that I would use. If I look only at tremor, I would say NFL is not going to be helpful in longitudinally look at Parkinson disease. But yes, this is telling you again that a potential earlier, earlier signal can be seen in patients that have, again, likely, we don't know the details, but like all the details, but likely a specific phenotype. A specific phenotype that has some specific characteristics. We all know that akinetic rigidiforms and people that have akinesia, they seem to be having a more severe disease, maybe more axonal injury, and depends on the location on where this damage is occurring, matrix of the striosome, whether or the striosome per se, so can be a difference. But that is very interesting because this carries through the entire column other than for tremor. Tremor, no.
I'd like to stop here and kind of like use this up because we're running out of time also. And I wanted to kind of talk about, we're going to talk about the limitations of the study, but really not all studies can do everything. So where do we go from here in terms of future studies, and what could have added to this study, perhaps?
I would like to tell you my opinion, but I want to hear yours because that is an important one. I would like to know what you think because we may be on the same page. This shows that NFL can be helpful in some specific cases with some specific phenotype as a potential diagnostic biomarker. I'm not sure because we talked before, it's quite a specific. It can be present in many other circumstances. As our colleagues in the editorial accompanying this paper, as well as in the paper, the idea is there can be a biomarker of degeneration. Once present, you can then look what kind of degeneration we're dealing with and get ready to try to implement changes to reduce the risk of any degeneration. To me, it's very interesting that this is becoming potentially a prognostic biomarker, not necessarily in terms of severity, but clearly can tell us a problem of severity, but also because it can identify a phenotype that we know is already associated with prognosis. What to do from now? There are a few things to me to be done. Number one, we need to be understanding the longitudinal lifetime phenotype of a patient. So we don't know anything about the premotor, the non-motor or premotor or non-motor symptoms. We don't know anything about genetic predisposition. We don't know anything about environmental exposures. And I don't blame my colleagues, but this is not the part of the study. But clearly there will be an expansion to be done. Our colleagues are very honest and are telling that two things are important. The composite score was much better. This means that there's a need to have a much more understanding and much more information to complement this biomarker. And the idea also of having multiple biomarkers, there is multidimensional approach, exploring different cascade, different biochemical markers that can then identify subtype, become prognostic biomarker, potentially diagnostic biomarker, but clearly something that can guide us in treatment and management. Because the best diagnostic biomarker is a biomarker that is not invasive, is cheap, is reliable, and it gives you a 99.9 possibility that you're not wrong. And I doubt that we have anything like that. The only one was the COVID test was giving some close to these numbers, but was not having all the characteristics. So I think we had to go to a much more complex, convoluted, but clearly much more detailed group of information that will explore the lifetime of our patient to intervene early and potentially identify phenotypes that can be approached in a different way. But this is a good study. This is again, we keep saying this is a good study, and this is something that can help guide further research in a different direction. What do you think, Dr. Choudhury?
I think there's two take-home points from this study for our listeners. Number one is the study sort of confirms that neurodegeneration can be detected many years before symptoms occur, and which is the prodromal state that we see in Alzheimer's disease. And now we have ways of looking at pathology in Alzheimer's disease, and we're looking for ways of doing that in synucleinopathies. And I think NFL could play a role in that once we identify different prodromal states phenotypically, or using a combination of biomarkers, perhaps hyposmia. COVID's kind of thrown a wrench in that, but maybe hyposmia, maybe autonomic dysfunction, maybe gut changes, whatever. And then maybe early blood test, a combination of blood serum markers of NFL, maybe CSF biomarkers, but basically a combination, color vision, etc. All of these things that are coming through together to then identify pathways that our patients will take over time. So I think that would be where we would be able to utilize this information. I do think we're still several years away from using it in a clinical setting meaningfully. We have to understand the range of NFL. In this study, it was anywhere from 0.99, which was the minimal detection threshold, to 755. So we really have to understand how this changes with age and other diseases so that we can implement them in a screening phase in a clinical setting.
I wanted to ask you a question on this point, because it's important. We both are clinician and researcher. We both see patients. If today you had an NFL test, you can order in blood or CSF with minimal problems with your patient, whether they have Parkinson disease, would you order it today to understand? Would you order it, yes or no?
Probably no.
I agree with you.
Just similar to how I wouldn't order serum A beta 42 yet.
Very good. Makes perfect sense. I agree with you entirely. It, as you say, is not ready for the prime time, and it's not ready. And it can be a piece of the puzzle. It can be a piece of the test. It can be something that we can do in the future. But we need, and our colleagues did a good job, but I think we need to have much more granular information, much more detail regarding the subtypes, age of onset, characteristic of onset, demographic changes that can move the thermostat of where we are with one or other biomarkers, because we all both know that one biomarker, whether it's in skin, saliva, CSF, blood, is not going to be enough.
Yeah, and I think that pretty much wraps up the study. I think obviously we would need pathological confirmation in the future and many other things we could do, but I think that wraps up the high points of the study. Any final thoughts and comments?
No, I think I agree with you. This again, I want to say one more time, because this study was very good. Was very well written, were very well designed. Was let me say a honest study. It was saying exactly what it was. It was saying about the limitation. It was moving the way in a honest way, the interpretation of results. There were no pitfalls. There were not things that were, and there were not over the top claims about what this was about. So that is a very important thing. Kudos to our colleagues. They did fantastic. And we love the study. Clearly, me and you are here to work and tease this apart, but was a very good study, and it was I enjoyed very much. It was very enjoyable to read and to be commenting on these particular results.
I agree very much. Great study. Thank you so much for joining us.